Melanie Stone. I'm an assistant professor of family and community medicine here at UT Health, and I direct our community engaged learning program through our CHWs Center for Medical Humanities and Ethics. And I have been working in the health literacy field since the mid 2000s. Before I came to the university, I was actually with CareLink. Those of you in San Antonio may know about CareLink. It's our university health system, our county hospital systems financial assistance program. And that was really when I developed this interest in health literacy, because many of our patients in the hospital system were unable to successfully navigate the healthcare system. And I was seeing the issues that they were having with transportation and childcare and all the other factors that affected their ability to be successful in their healthcare, while at the same time seeing how our providers unfortunately didn't recognize that or understand that, and would tend to label the patients as non-compliant. And I was like, no, that's not that's not what's going on here. And so I became involved with some local health literacy initiatives here in San Antonio, and through the years I've done more with statewide and national, and now even international. There's a lot of momentum in the field of health literacy. I'm sure that you as community health workers have been very aware of health literacy and the work that you do. Hopefully some of you had a chance to review the continuing education module that we provided you, I think yesterday. If not, no worries, you can do it at your leisure, but that will lay some more of the foundation of what we'll be talking about today. So with that, Shan, if you can go ahead and move to the next slide, please. So I just wanted to acknowledge some of my colleagues who have been involved with health literacy, and of course the program that allows this training to happen. Thank you, HRSA. Next slide. So today, and I know that we've lost about 20 minutes here, so we'll go quickly through our health literacy information, and then I do want to kind of hone in on one of our health literacy skills called Teach Back, and hopefully we'll have time for you to practice that, what it's like to do Teach Back, and then we'll come back together. Okay, next slide. So let's start off with a health literacy scenario. And so this is a documented case that I'm going to read it to you, and then I want you to reflect and let me know, is this something that resonates with you? Do you have similar situations in your encounters? So we have a 2-year-old diagnosed with an inner ear infection. She's prescribed an antibiotic, and her mother has some understanding. She knows that her daughter needs to take this medication. She knows it has to be taken twice a day. So, those instructions were made clear to her. Then she gets the bottle from the pharmacy, and she decides that it doesn't really tell how to take this medicine. And so, she ends up taking, she fills a teaspoon with the liquid because it probably says take, 1 teaspoon. And instead of giving it to her daughter by the mouth, she pours it into the ear, thinking, well, it's an ear infection. This is really illustrative of what health literacy is like. Typically, people have some understanding of health information, but maybe not 100% accurate understanding. And the ramifications of that, and when it comes to medical care, can be very severe. As in this case, she probably made the infection worse. Maybe they had to now go to the ER. And, simply clear communication by the provider, whether it was the doctor or the pharmacist or both, could have prevented this situation from happening. So let me pause. Does this sound like situations that you may have encountered with your own family, with extended family, with your the community members? And I can open chat now, so that's great. Oops. Well, I thought I could. Let's see. And you can also feel free to unmute yourself.
Does anyone think this is a reasonable scenario?
Hi, my name's Jackie May, and I'm a community health worker, but I'm also a retired pharmacist. So this kind of story is something that we're continually reminded about during our training. And I think situations have improved quite a lot in that most pharmacies can now, or we have language translations for the directions and things like that. But you are quite right that it is of the utmost importance to make sure that the patients understand what the directions are and to check for that.
Thank you. And I do completely agree with you that pharmacists are often a resource for people who isn't really taken advantage of enough. I personally will rely on my HEB pharmacist to guide me. She's had, I had a surgery a few months ago, and she helped me in a very accessible way. You can just call them up; they'll immediately answer your questions. And so, I'm so glad that the pharmacists are getting some good health literacy training. Yvette talks about, what happens when the language is not provided in the language that the person's most comfortable with. And there's a really sad health literacy scenario that we can't quite pinpoint, but I believe it happened because it's been talked about enough over the years, of a woman who was given a prescription for Dilantin for her daughter. I believe this was in California. And the instruction said to take the Dilantin once a day. Well, this was a Spanish-speaking family. The mother was probably, a little bit scared, a little bit frantic. She reads once as once. And so, as you can imagine, she gave her daughter 11 of those pills, which, unfortunately, with a toddler, that caused her to die. And so, I mean, these are really serious. Those are the language issues, the health literacy issues. Okay, so let's move on to the next slide here. All right, we're going to do a little activity together. So this is a paragraph that we're going to read together out loud. So you can feel free to unmute yourself so I can hear you and I know when you've been reading it. As you'll see, some of these letters here are not in the correct order, but we're going to read it anyway. Okay, so let's start with the title. The National, and read with me, the National
Notice for health literacy.
National Action Plan for Health Literacy.
Seeks to engage.
Notice plan to
The national
hard to read this.
National Action Plan for
literacy
Health
To engage
literacy
Action
seeks to
Plan for
engage.
literacy.
the National
and families
Action
in
Plan
a difficult
Is this in Russian?
Organization,
conversation trouble to improve
professional,
To improve health.
Yeah,
and
that's
families
right.
in a
Need
painful.
Russian. It's just some of the letters are flipped.
to engage
NRV with
I think I would need to ask for help.
That everyone.
When you do translation,
organization.
translate.
We're gonna go ahead and stop. So,
yeah, because that was hard.
That's fun.
we're seeing all the slides. Okay, we're back there. So I'm going to stop the pain right there. So as you all figured out, this was some of these words were flipped around. And so now that you've read this paragraph, I'm going to ask you some questions about what you just read. So can anyone tell me what is one principle that the National Action Plan is based on?
No.
No brave souls are going to attempt that. Okay. Well, as you can imagine, it's because it was very difficult to read. So I like to use this exercise when we're talking about literacy because it gives us an idea of what it's like when a person has low reading skills. So even if you can decipher the words that some of you were able to do, as you went along, the point is you're not going to comprehend what you just read. So you can maybe get through it, you can decipher it, but are you going to actually comprehend? And that's a critical skill when you're talking about health information. So if you're someone who struggles to read and have that much trouble, are you really going to understand the health information that we're providing you? Next slide. If you're not muted, if you don't mind, please muting yourself. We're hearing some background noise. Cheyenne, next slide, please. Okay, so this is a little video, Cheyenne, if you can just go ahead and click on that.
The embarrassment, the shame.
Did you hear it? Okay.
I mean, it's just overwhelming. It really is. It paralyzes your thoughts completely to think that you may say something or something is put before you to read and you can't read it. I mean, you live with that on a daily basis.
So this is Mrs. Walker. She did some interviews for a health literacy study describing what it's like when you have this struggle to read, what it feels like when you go to the healthcare system. And, a lot of providers would look at Mrs. Walker. She's very articulate. They wouldn't suspect that she had struggles with reading or literacy. So, again, a lot of people do hide it, but it's a burden that they then carry. Next slide. So this is the long-standing definition of health literacy. The Institute of Medicine developed this many years ago, but it's probably the one that you're familiar with. It's the degree to which individuals have the capacity to do three things: obtain, process, and understand basic information and services in order to make healthcare decisions for themselves and their families. This definition we're going to tweak a little bit in a moment, but I just wanted to kind of get us all on the same page. Next slide. So when you're dealing with challenges of having low health literacy, these are the areas that you might struggle with. Directions to a clinic. It may not sound like that big of a deal, but if you have trouble getting to the clinic, that's going to then now make your time with that physician less because, now you're late to your appointment. You're going to have less time, less opportunity to talk with the healthcare team about your issue. The communication between the patient and physician can be challenging if there's low health literacy issues. We talked about medication instructions, being able to make your follow-up appointments. Again, the CareLink providers saying people were non-compliant in their follow-up appointments really had more to do probably with low health literacy than with them choosing not to make those appointments. Are you able to give informed consent? If you're having a procedure and you really can't understand those very long and complex forms that you have to sign, are you really truly giving consent? So these are, health insurance. If you're fortunate enough to have health insurance, the navigating health insurance is probably one of the toughest things you can do in healthcare. Next slide. So this is an updated health literacy definition, which is great. So Healthy People 2030, our country's national public health agenda, has recognized that we need to differentiate a personal health literacy, which was the definition that I provided you earlier, with organizational health literacy. So the personal health literacy is that individual's ability to get the information, understand it, and use it. But it also recognizes that organizations in the healthcare system has responsibility to make sure that they equitably enable individuals to do those actions. And so, the changes to this definition really are emphasizing a person's ability to use that information, not just understand it. May understand it, but then can you actually act upon it? And part of that acting upon it is removing some of those structural barriers that the system has. And then we are, incorporating this public health perspective now because we're thinking about the larger issues that are contributing the social determinants of health, all the issues that go into navigation of healthcare. Next slide. And now it's really exciting because there's a focus on this concept of community health literacy. This really became very evident during COVID when, we realized that a lot of people in our communities either don't trust or don't use traditional healthcare clinics, hospitals. There may be reasons why, historical racism. There may be, they may not feel respected when they go to those organizations. They may not have access to them because they don't have the financial resources or insurance. And so a lot of people will go to their trusted community organizations. It could be a community agency. It could be a social service like a housing program. It could be a church. It could be schools. They may rely on social media and mass media. So there's a lot of ways that people are getting health information, and it's the responsibility of all of these places to really make sure that their information is accurate and it's trusted and it's accessible to people. And so, the responsibility for healthcare is now disseminating widely. This is where CHWs really have a big role to play because you're connecting people to these different entities and serving as that conduit of someone who has that trusted healthcare information. Next slide. All right, so what does this have to do with being a CHW? So as we said, you serve for a lot of people. You're a trusted source of health information, but you're also embedded in the community. You know the language, you know the resources that are in that community, and you serve as a bridge. And so I just want to stop again and see from those of you who have been practicing as a community health worker, does this resonate with you? Do you feel like people are trusting you with health information to be provided to them in a way that they can understand? Oops. Did we hear? Cheyenne, you moved on. Did we hear? I was checking chat to see if anybody is responding. Okay, so some people, and for some reason my chat won't stay down. It keeps moving on me. But thank you, Rose, Veronica, for saying yes. Anyone want to comment, unmute themselves and comment?
You guys are lucky that I'm sick because I'd be talking, but I said yes, but I have a sore throat. I wish I could talk.
Sorry.
But I
Okay, thank you. I'm so sorry that you have a sore throat. It's definitely going around.
Okay. Community health worker, we have to help to be able to educate these patients and support them with this kind of stuff. So they may ask us questions. So we need to be educated on it and also be able to speak with their doctor, be in close contact with them to ask the questions and whatnot, because we are a lot of times their go-to.
Yep, perfect.
And then I also want to add, I'm Rose Bailey, by the way. So I work for Baylor Scott and White Health. And so a lot of times I'm able to send education through our patient portal to our patients for like further education with like any hospital follow-ups and things like that. So I'm glad that we have that available as a resource to share.
Yeah, I'm really interested in the idea of sending information through a patient portal. I think there's a lot of opportunity there. And I do hope that we're utilizing health literacy practices and plain language and all the good, techniques to make sure that we can disseminate that very effectively. So thank you for bringing that up. All right, Shan, let's move to the next one. And good comments there in the chat. I'm having trouble staying in the chat. Self-advocacy. Yep, self-advocacy. And that's a lot of what we'll be talking about today. Okay, so time for a little quiz, and keep the comments going. Those are great. Pop quiz. So how many Americans struggle with health literacy? Would you say it's A, 10%, B, 50, C, 75, or D, 90? And you can put A, B, C, or D in chat, or you can say it out loud. So, oh my gosh, come on, chat. Let me click out of here and go back in.
So there's a lot of people going between C and D, 75 and 90%. A couple B's.
Okay. Yeah. Okay. Yeah, you're right. Seeing a lot of C's. Well, those of you who said, next slide. Next slide. Those of you who said D were correct. So if you can believe it, 9 out of 10 adults have this struggle. I know it's shocking, but the point is that you may not have this struggle all the time, but it could be situational. So let's say you normally have pretty high health literacy. You go into the doctor's office and you learn that your child is going to need surgery unexpectedly, or maybe you get a cancer diagnosis. Well, in that situation, your health literacy might plummet because now you're got a lot of other concerns. You're having emotional stress, and you're not going to be able to comprehend like you normally do. And so some people have low health literacy all the time, and those are the ones that are in the below basic or basic. A lot of people, more than a third of our population, struggles with it all the time. And then other people, may be having better health literacy, but it can ebb and flow. And so this was an assessment that was done a long time ago, but unfortunately, it was the only national health literacy assessment that we have had. So we still cite this information, and surveys that have been done since that time, maybe not in this nationally representative way that this one was, but they are still indicating these same types of numbers. And so this really hasn't changed. If anything, it's gotten worse. And so it's a big problem for our country. And next slide. So those people who are in the basic and below basic, as we have been talking about, they can have serious or even deadly ramifications, especially when you're talking about taking medications or following hospital discharge orders. Those are serious and important skills that if you mess up can really have a detrimental effect. And so making sure people understand 100% of what they need to do, what action they need to do, is so critical. Next slide. And so health literacy is also now recognized as a health equity issue because certain groups are more at risk for having low health literacy and being in those basic and below basic groups. And the high risk groups, people who tend to have lower health literacy, are our senior population. And, seniors have a lot of medications and a lot of health issues that they're working with. And so it makes sense, right? If you have a lot of challenges, then it's, you're going to be more at risk. people who have limited education, members of ethnic minorities. There's a lot of time due to cultural and language issues. If you're unemployed, and then there's been studies that document people who are insured by Medicare or Medicaid or more at risk for low health literacy. Next slide.
May I interrupt?
Of course.
Thank you. I always go back to this because it fascinates me.
Okay.
People with mental health challenges.
Mm-hmm.
That's how I became an advocate, first off for myself, and then so I just wondered, is mental health disorder, is that another? Do they mention anything about that?
That is a good question. So I think it's been brought up before by a group of CHWs, and I don't know the literature on that. I think that's a kind of a newer field, and so I'm going to do my because it's been brought up now a couple of times. I'm going to do my my due diligence and see what kinds of research has been done with health literacy, with mental health specifically, because I don't know enough. Okay. So, yeah. Or we can send out maybe an email to this group if there's any like good resources I have for you all too. So, but thank you for bringing that up. I think it's so important. Okay, and then so now we're going to move into some strategies. And this, again, if you had an opportunity to take that Health Literacy 101 continuing education module, they'll have talked about things like plain language, open-ended questions, and teach back. So we're going to just talk about, just in general, these are, and I'm sure you all learn this, in your role as a CHW, you probably are very well equipped, so you can teach us. But these are just kind of some of the communication skills that are important when you're trying to communicate health information. So demonstrating empathy, and as a CHW, I know you do that, but just making sure that person feels listened to, feels heard is so important because they know that you care. Of course, being an active listener, and then asking your client to have open-ended questions. And so when you ask a yes, no, or a closed question, then they have the opportunity to just say no, because maybe they feel embarrassed. They don't want to ask their questions, or they think, they'll be judged by that. But if you instead phrase it as, what questions do you have for me? It lays the foundation that they expect, you expect them to have questions. And so it's just a simple reframing of the, do you have any questions, at the end of your conversation, to be, what questions do you have for me? And then chunking and checking. So that's just breaking up. If you have a lot of information that you're trying to share with them, putting it into small, bite-sized information. As adult learners, we also struggle, just like kids do, to take on too much information at a time. So it makes more sense to do it bit by bit, using plain language. And then in your case, you might want to help interpret some of the maybe jargon that the doctors are using with them. So if they say, well, I don't really understand what, they keep saying blah, 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 hypertension, I don't know really what they mean. That's an opportunity for you to teach them, well, when they say hypertension, that means, high blood pressure, and high blood pressure, blah, 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 explaining that. Okay, next slide. There's a few more of these strategies. Oh, okay, before we go to the next one, let's just do a quick practice here. We're going to take some terms, and you're going to just shout out, because we don't have a lot of time to write it in chat. So just shout out, next slide, please, what the term would be. So how can you say this more clearly? Next slide. Okay, so how can you say this more clearly? First up, go ahead and click. Okay, so we just said hypertension. What would you say instead of using the term hypertension?
High blood
Blood
pressure.
pressure.
Okay, great.
Yeah.
Next
Mouth.
Yeah.
Out.
Great. Next one.
Low blood sugar.
Blood sugar.
Low blood sugar.
Heart.
Cardiac.
Heart.
Okay. Next, one more. Ooh,
Not
benign.
cancer.
Not cancer.
No cancer.
Cancer.
Do you all get it where a lot
bad.
of people think benign sounds
Benign.
bad? So they're like, oh no, it's benign. And you're like, no, that's a good thing. That's what you want. So, okay, you guys are great at that. So next slide. So just a few more of these strategies. You want to make sure that you're including family and friends when you, if you can, if the patient or client wants you to, but including the more people will help the patient remember the information you're telling them. And then they also might ask some questions, clarifying questions. So involving others is really helpful. Telling stories is huge. So again, especially when you're talking about medical stuff, it's very hypothetical. It may not make a lot of sense, but if you know that your client is really into cars, well, then you can relate, if you're able to relate, how the functioning of the car works and what the oil, does to the car is similar to what, your blood is doing in your body. Like just ways that it'll stick with them and make more sense to them. Of course, considering cultural context, your very diverse population that you're working with. Culture may impact how they view healthcare in a lot of ways. And if maybe they're haven't been in our country for very long, they may be thinking about how healthcare is happening in their home country, which could really be a very different system. And then using the teach back method, this is what we're now going to switch our focus to. So we've sort of laid the groundwork of what health literacy is, why there are challenges with low health literacy. And this technique of the teach back method is one of the most important skills that you can utilize as a person who's communicating health information. If all of our providers use teach back, we would drastically reduce medical errors. And it's really a very simple technique. It doesn't take very long to do. And so at the end of this, I hope you'll agree with me that using teach back is a good thing. So next slide. So we're going to talk about what it is and what it isn't. Sometimes it's important to talk about a concept by showing what it isn't. And then we're going to, like I said, have time to actually practice so you feel comfortable doing teach back. Next slide. Okay, so we're going to start off with what it is not. And this is a scenario that we talked about earlier where, the CHW here or the healthcare provider is saying, at the end of their visit, they need to check off that, hey, I left this patient or client, with information that they needed and they understood. Because that is part of a lot of these EMRs and, patient charting is, saying, did that patient understand? Did you make sure they understood? So what are they going to say? Well, do you understand? And this woman is obviously confused, but she doesn't feel like she should say no. It's hard to say no to a question like that, especially when you know that person is trying to move on to the next client. So she says yes, and she leaves the interaction not really knowing what she's supposed to do. Next slide. Okay, so what is teach back then? So simply the concept is that you're asking that person to repeat back to you in their own words what it is they're now going to know or do. Really important here is what are they going to do? So it allows you right away during that interaction to see if there's any gaps in the information or any misunderstandings. Like we talked about in that very first scenario, the mother of that child understood some aspects of what she was supposed to do, but not completely. And if that provider had used teach back with her, then they would have caught that, no, you don't put it in the ear, you put it, you give the by mouth orally. So it allows for some immediate clarification, which can really be very, very important when it comes to healthcare. Next slide. Okay, so this is just showing that they are now on the same page because they have communicated to each other. Next slide. So it's using a non-shaming way to confirm that that patient understands health information. And as a person who's having to do teach back, it helps you know that you understand it. Whenever you're trying to think about a new concept, it's one thing to have it in your mind, and it's a different altogether when you try to voice it. And if any of you have ever tried teaching to maybe a family member something like algebra that you thought you knew in your head, but then when you try to actually explain it to someone, you're like, oh, I don't really get it. So it's the same thing here. If that person can confidently teach back what they're supposed to do, repeat back what they are to understand, then it really confirms that they understand it and they're equipped to now go take action. All right, next slide. So this is really just a summary of what teachback is. It is evidence-based. There is research surrounding this help that using teachback really does improve health outcomes. And I think there's a slide. Well, there's evidence, and I can share that with you. I don't know if we put it in this presentation, but there's a lot of studies on that. And why are we doing it? Because we can't assume that just because you say something to somebody that they understand it. You may think you're the best communicator and the best presenter of information there is, but you don't know until you've actually asked that the recipient of your knowledge whether or not they got what you were saying. And so the how of it is just simply asking the person to tell you back in their own words what they learned. Okay, next slide. And so let's talk a little bit more about how to do teach back. Next slide. So one of my health literacy colleagues, a couple of years ago, they published something called the 5 T's for teach back. And really, this just gives you some actionable steps when you're doing teach back. It's a pretty simple concept, as we've been saying. But if you think about it in these 5 T's and you practice it that way, it'll become automatic. You won't always have to think about the 5 T's because it'll be what you do. But when you're still learning and trying to do this really well, it's helpful to look at this. So the first one is triaging. You provide a lot of information to your clients. You can't do teach back on all of that. You have to decide what is really the most important thing that you want them to do when they go home, or when they're not with you anymore. What is the main action you want them to be able to take? So when you're thinking about triage, it's really a hard thing for our health providers who are still in training, because they don't have the experience yet to really know what are the most important topics. As CHWs, you probably know already kind of like what are the things that people are struggling with. And so first off is triage. Next one. Using tools. And so when you're doing your health information, when you're providing your health information, you can talk and talk, but once you provide some sort of tool to a person, it really helps make it more tangible in their mind. And so, as you all know, people have different ways of learning. Some people are better with oral information, some with visual, some with hands-on, but you want to make sure that you provide a variety of ways that you're explaining that information, because it's helpful no matter what to have that for each person to have a variety of ways. And so it could be using some sort of model. It could be a graphic or a poster. If you're wanting them to show you how they're going to take their pills and you've given them a pill organizer, well, then have them actually show it to you. What are they going to do? How are they going to take their pills? And that way you'll know right away. If the patient has to start using an inhaler, have them show you how they're actually going to use it. You've probably all seen instances where someone thought you spray the inhaler on your neck because it looks like a perfume spray bottle. And if that person then, is showing you, then you can correct it right away and help them with that. So make sure you're using a tool to explain your information. Next one. Take responsibility. This is so important. And this is the step that I would say most people struggle with, whether you're an experienced CHW, whether you've been a doctor for a long time, whoever, they often don't do just this little bit, which is leading into your teach back. What you don't want to do is have the person feel like you're testing them. And so, if you just say, hey, Pam, I'm going to, I just gave you a lot of information. Now you tell me what, I just told you. Like, you're going to all of a sudden feel very scared, like you're being given a test and you're going to clam up and not be able to do it. So you don't want to do that. You want to put the responsibility on yourself as the health educator. So you need a little bit lead in, to introduce the teach back. You want to say, well, Pam, we've talked a lot today. We went over a lot of information, and I want to make sure that I did a good job of explaining to you how to take your pills today. And so, can you show me how you're going to do it when you go home? So now Pam feels like I'm not testing her, but instead I'm trying to make sure that I did a good job because I know that, it's a difficult and challenging thing. So taking responsibility is critical. Next one. So this is the actual teach back step where you're either having them tell you or show you, depending on what it is you're teaching them. They can either tell you what they're going to do or they can show you with, an actual tool. Next one. Okay, so you've done all these steps and then go back one. You've done all these steps and maybe they tell you back and it's perfect and then you're great. You can, confidently move on. Maybe they've done it all and there's like a slight error in what they're saying. Well, then you need to go back and go through these steps again. So you're going to do your teaching back to them in a slightly different way. Maybe you were using some terms that they didn't understand, so you want to change your language, or maybe you want to bring in a different tool, but just don't teach in the exact same way because there was obviously something that didn't click with them. And then do your teach back again, make sure now they're able to fully tell you, and if not, you're going to have to go back again. So this is the accountability, is making sure that they get it correct before you leave. Okay, next one. So we'll skip over this. This is just talking about the triage, which we've already done. It's just making sure that you find out from your patient what they already know about something. You don't have to teach them things that they already understand well. And so you just want to know, have a conversation with them, find out what they know about the topic, and that'll help you do the triage. Next one. Again, emphasizing that taking responsibility. If you say it this way, no one's going to be comfortable with that. So you don't want to say it like that. Instead, use the lead-in that we've been talking about. Okay, next slide. Yeah, they'll just say, oh, I don't, I forgot. Instead, say that was a lot of information. I want to make sure I did a good job of explaining. This topic, is confusing to a lot of people. And so tell me in your own words how you're going to take your medication. Next one. Okay, let's do this example together before we do our breakout. So this is a real life example, instructions from a birth control package. So this is the scenario. You're a woman who had sex the night before. The next day you go to take your birth control pill and you realize that you've missed 2 of your active pills, and you're freaking out because you had unprotected sex the night before, and you're like, what am I doing? What should I do now? Well, you turn to your instructions that are, if you've ever read the instructions in a birth control packet, they're sound like this. So this is what it says to do if you missed 2 pills. If you miss 2 light pink active oral contraceptive pills in week 3 or week 4 of your packet, and if you are a day 1 starter, take the 2 OCPs you missed today and 2 OCPs tomorrow at the regular time. Now, if you sit down and you're calm and you really figure this out, you can understand it. But if you are freaking out and you read something like this, is that going to make a lot of sense to you? Probably not, right? So let's turn and see what a health educator did in this scenario. So this is, we asked a health educator, how would you handle something like this when you're talking to your clients? So the health educator, and as we go through this, I want you to be thinking about, is this health educator using those 5 T's of teach back? Because we're going to identify them if they are. So so keep that in mind, and I'll ask you at the end. So the health educator says, I asked the client, okay, tell me, if you miss a pill, what should you do? If she doesn't know how to explain it to me, right there, I already know, okay, she's not really grasping this information. So I go over it with her again. This is what you do if you miss 1 pill. This is what you do if you miss 2. I give her an example. Let's say you left town for the weekend and you left your pills at home. Very common scenario. So now you've missed 2 pills. What are you going to do? I also give her the pill packet. If she can't show me what to do, I really don't feel comfortable because they are bound to miss their pills. It's going to happen. So it's just like, okay, if you got to really break it down for them. All right. So can anyone tell me what is on here that indicates triage? Did the health educator triage this? So I would say it's if you miss a pill, what should you do? This health educator has experience in this type of education. She knows that it's, I think somewhere over here she said it's bound, it's going to happen. So she knows this is the triage that she needs to teach her client about. What about a tool? Did she use a tool? Good. So someone said the pill packet. Yes, the pill packet itself is a tool. So she's giving that to her so she can demonstrate and show her. I think there's also another tool here, and think more creatively about what a tool might be.
An example?
Yeah, very good. So giving that example, it's kind of like giving a story or a scenario is another tool. Good job. So she had 2 tools. What about the teach back step? What was that? So right here she says, if she's actually does both, right? She asks her, what are you going to do? And then show me how you're going to take the pill. So she does teach back in both of those ways. And then what about the repeat step? Does she talk about using that step? I would say it's this, go over it with her again, right? So, if she doesn't understand it the first time, she's going to go over it again. And some of y'all are saying that in the chat. Thank you. What about, is there one more step that she didn't do? So think of the 5 T's. What of those 5 T's have we not talked about?
Well, she didn't ask her to explain how she like a teach back.
Yeah. So remember, I said this was the step that most people forget, and it's such an important one. So remember, taking responsibility. So does she, she says, here, so you missed 2 pills, what are you going to do? What would have been a better way for her to say that? Did she take responsibility there? No. So, she could have said, well, a lot of my clients, they have trouble with, understanding how to do this. I want to thank you, Susan. I want to make sure I explain the information to you. So that's all she had to do, was just add that to her request for the teach back. Okay. Let's turn now to the next slide. We're going to watch some videos. Looks like we just have one here. So we're going to watch an example of teach back. This is just a quick, short, couple-minute video, but I want you to see how this provider does it, and then we'll talk about it. So Cheyenne, you can go ahead and show that.
It's like, now that you know this, I know you've got friends. When they ask about this issue, how are you going to tell them? What are you going to say? Well, one of the things that you can do if you have a really bad pain, I mean, where you can't stand on it and it's really getting in your way, is to use what I call, this is my little pain protocol here. It has ibuprofen, which decreases those little cells I was talking to you about, the inflamed part, and your Tylenol that just works on the pain. And the I is for ibuprofen and T is for Tylenol. And this just shows you how to do it over the course of the day. For breakfast, lunch, and dinner, there's an I, so you use ibuprofen.
Right.
Because you have to have something on your stomach.
That's right.
With that one. Because this one will irritate your stomach.
Yeah.
So in between meals and at bedtime, you use a Tylenol.
Right.
This way you get something every 3 hours. You don't overdose on either one. So it's IT, IT, IT. And if you do that for a couple of days when it's really bad, then you can just go back to your regular regimen. But this usually breaks the pain pretty nicely. So I know you have a lot of friends with arthritis. How would you explain it to them?
Well, for breakfast, I take I. 10 a.m., I take T. Lunch, I take I. 3 p.m., I take T. I at dinner. And T at bedtime. Is that correct, Doctor?
That's going to work just fine.
Thank you very much.
All right. So what did y'all think about that interaction? Pam liked it. Do you think she used some of those teach back skills? Did she have a good tool that she used? Yep. So y'all are saying she had a visual, she had an actual written document that he can now take home with him that like shows exactly what he needs to do. And then, yeah, she abbreviated the names of those drugs so that he doesn't have to always read ibuprofen. Now he just knows I for that. It's a little cheat sheet, as you're saying. And then I liked how she did the responsibility, because maybe this man doesn't have a wife or children, but he has friends. Maybe he's at a senior center, living at a senior center. And so she related the teach back to his friends. What are you going to tell your friends about what you're going to do? So, that's just goes back to making sure you know enough about your patient to know what they need. So anyway, I just wanted you all to see an example. Sometimes we show some longer videos of a good scenario and a bad scenario, but in consideration of our time, we're going to go ahead and jump now to our next slide.
It's like,
and
now that you know this, I know you've got friends. When they ask about this issue, how are you going to tell them? What are you going to say?
Are you able to
well, one
move
of
to
the
the next
things
slide?
that you can do if you have a really bad pain, I mean, where you can't stand on it and it's
Should be able to
really
just
getting
click
in your
on
way,
it
is to
out of
use
that
what
video.
I call, this is my little pain protocol here. It has ibuprofen, which decreases those little cells I was talking to you about, the inflamed.
Looks like Cheyenne's having some problems too.
Uh-oh. That was weird. Let's try this again.
We're on slide 34, if you're able to jump to that. So what I'm going to do while she's pulling that up is we're going to practice in your teams here. We're going to put you in some breakouts where you get to practice in a trio how to do a scenario. The scenario is how to use a pulse oximeter at home. So if you have had to ever teach your patient or client about how to use one, this is just a simple example of that. And one of you will get to be the CHW who's doing the teach back. One of you will be the patient or client, and one of you will be an observer. And so each of you is going to have your own tool that we're going to put in chat here. So if you have the ability to download it, that would be great, because we're going to put the file for the scenario so that the CHW can look at it and know what they're going to do the teach back on. And then we'll put the observation checklist for our observer. And I think we're going to just randomly put you all into breakouts, if that's okay. Oh, Cheyenne says we should skip the breakouts because she's having too many technical difficulties.
I didn't. I'm okay with breakouts.
Are you sure?
Yeah. Unless you want to skip breakouts.
I just wonder about our time. I'm kind of thinking, Cheyenne, because we're still seeing a blank screen on your end, and having people to have to download and put them in breakout groups. I think it's going to take longer than we have, and I think it's also a technical challenge. And I'm so sorry to our participants, because it's nice to be able to practice it, but I'm going to have to just ask you to practice on your own. And I think what we'll do is we'll end with our review of TeachBack, which sort of summarizes everything, and then we'll have time for some questions at the end here.
Sounds good.
Let's finish up these slides, and then we'll take questions for those of you who have questions. Okay, that would have been the scenario you would have practiced with. So keep going. You can go to the next slide.
Did you want to review the scenario?
No, we're not going to do the breakout, so you can keep.
Oh, we're not doing it at all. I thought you were going to stay as a group. Okay.
No. Okay, let's just summarize now. So what we've been talking about today with TeachBack. Next slide. And by the way, I see a lot of stuff on my screen. Let me see if that's hopefully you all can see the screen here, but I'm having a little trouble. So the first step is doing your health education with your patient or client. So you're going to make sure that you're using plain language. You're going to focus just on a few points that you really want them to understand. You're going to use those materials, those tools, resources that are culturally and linguistically appropriate, and then supplement with any visual aids that you might have. Even if it's as simple as just doing a drawing, that still does a lot. Okay, so that's first step. Next step is, so now you're going to confirm that what you just taught them, that they understand. And this is where you're going to do the teach back, either telling you or showing you. Next slide. And now this is the re-explaining. And so again, if that person isn't able to fully teach back correctly, then you want to make sure that you do praise them for what they did right, because you don't want to make it seem like they're a failure. You want to make sure that they have that encouragement and that you've reinforced the correct information, and then you're going to explain it a different way. Perhaps using some analogies. Maybe you're going to remove some of that jargon that you might have used without realizing. And then, of course, you're, saying that it's your responsibility to make sure that you provide this clear understanding, and then you're going to recheck with TeachBack. So that's just a summary slide. Next one. Okay, and then you're going to, those of you especially who are in organizations who are interested in helping their organization become more health literate, if they're not already aware, there's a toolkit out there that really takes this and integrates it into the daily practice of that organization. So there's some videos that the staff can view. There's some checklists like we were going to use. There's different ways to implement and then evaluate using TeachBack. So that website is there for you. Next slide. Those are some references if you want to kind of dive deeper into the literature, and then these resources are always good as well. So you can go ahead now. I think there's one more resource page, but you can go ahead and stop sharing. And then let's just have a few minutes to take questions and discuss.
So there are some questions in the chat box that I can go back to.
Okay, perfect.
While everyone else is thinking. I think it was about barriers. Has your research identified barriers to implementing TeachBack in the community health setting? And then what are the common barriers you encounter and how can we overcome them?
So encounters, I would say there hasn't been research that has shown barriers to using TeachBack. The number one barrier, especially in a clinical setting, is the provider saying they don't have enough time. If they have a certain number of minutes that they're allowed with a patient, they'll say, TeachBack, I don't have time for that. I have to get on. I don't, have time to go through all of that. Well, the other studies have shown that it only takes maybe 2 or 3 minutes more. But when you think about the time that would be saved when that person doesn't have to get readmitted to the hospital or come back, for an appointment, you're really saving that clinical practice time and money. In terms of the community-based setting, typically people in the community settings, organizations have more time with their clients and have not heard of any barriers to using TeachBack. It's really just more of a way to tweak the health education that you're doing.
Great. And then someone has something to say.
Yes, it's me. Can you hear me?
Go ahead. Thank you.
Oh, okay. My mom's 74, and so for the past 5 years, she's been having problems with her knee. So when she goes to her doctor, I mean, he's also Hispanic like her, and so he understands what she's saying. She's telling him, can I please have like a sticker for my truck, so a handicap sticker, so I wouldn't park so far. She goes, oh, just exercise. You just need to exercise. I mean, it hurts me hearing him saying that to my mom because I see her struggle. She's the person that she doesn't stay in a place. She said, saying in Spanish, mejor cansada que oxidada, which is I better be tired than rusty or something like that. You can translate that to her. So she doesn't stop moving in the house. I don't know how to do it because my sister gets furious with him too. And she gave it to her for 6 months, which it wasn't enough. When she needed to renew her license, it said, well, we need to have something from your doctor that what is wrong with you. And he didn't want to give her the explanation what was wrong with her so she can get her license. So we were, for a whole week, we were just mad about him not doing what he was supposed to do for her. So what do we do in this case?
Yeah, I'm sorry that you had that experience with her doctor. And unfortunately, I think all of us have had, poor experiences similar to that. So what do you do? I mean, it's good that she has you as her advocate. I think you now knowing, some of these communication principles, you can, well, okay, I'll tell you from my example, what I do, because I also had a mother who had a lot of chronic diseases. Unfortunately, she passed away a few years ago, but I had to do a lot of interactions with the healthcare system myself. And one thing that I've started doing after, becoming, more equipped with a teach back is I do something called reverse teach back as the patient. And so I will summarize with the doctor or the provider, so just to make sure I understand, this is what I understand about what you just told me. So if they're not doing it, if they're not taking the initiative to do it, you as your mother's advocate or, the patient advocate as a CHW, you can do reverse teach back and just make sure that, what you think is the most important thing was understood correctly. And my other advice would be to use the healthcare team. So if you're not getting good communication from the doctor, then maybe try working with a nurse practitioner, pharmacist, social worker, MA, and, see if that can be, where you have more time and interaction. So I know that didn't completely answer your question. And yeah, and it's very frustrating to me when healthcare providers don't use teach back. I know, Shan, you said that. So, but that's our role, right?
Melanie,
we're changing the healthcare system by advocating. Mm-hmm. Go ahead.
Do you teach this with your med students?
We do. So we have this as a mandatory session with our med students that started in 2015. And we also now do not just med students, we do the other healthcare professions as well. And then we're trying to think of ways for them to not just have a one-time experience, kind of like what you're having now, but to keep reinforcing it throughout their curriculum, giving them opportunities to practice it.
Great. Someone would like the link to the organizational health literacy reference. I didn't find it in the references or resources, but if it's on your slides, I can copy and paste it, or if you can find it and put it in the chat.
I see that Joel asked that. So when you're asking for organizational health literacy, was that they always use Teach Back Toolkit? Is that what? Because there's different ones, but I know that's what I talked about on slide 41, Shan, and that's, I'm trying to see if I can open it here. That may be what Joel's referring to.
Okay, let me put that in, and then these slides will be going out, so all the references and the resources will be in them.
Oh, okay, great. So you'll have it in there. There's a few more at the end of the I think it's in a couple of different places.
Yeah. There's a comment from Jacqueline. If you're unable to communicate with your medical provider, do not be afraid to change providers. I actually just this week finally worked up the courage to change providers. I don't want to hurt my provider's feelings, but I just felt like we weren't diving. So yes, agree with that. I'll mention the same thing with your kids or your dependents, your children, your elder adults. If you don't like that provider, then find someone else who you do communicate with, because evidence shows that health outcomes are. What we've talked about today, that health outcomes are better when you have good communication with your provider. And so share that with your clients as well. Any other questions?
But yeah, I think that's a good point. Someone mentioned at the beginning about, self-advocacy. And I think as a CHW, one of your, mandates is to make sure that your client and your patient has the ability to really be empowered to make their healthcare decisions and take control of their health. And so when you start using Teach Back with them, or teaching them how to ask for these different concepts, do you reverse teach back, all these different things. It's really going to help them feel more comfortable in that provider scenario and not be afraid to ask questions, because a lot of the times it's really people feeling like, oh, well, that person's so well educated, they're going to think I'm stupid. No, the healthcare provider, their number one goal, the reason they're there is to make sure that you have benefited from, this health information or health advice. Otherwise, they have no point. Like, what is their point of being there unless they're relaying that information to you? And so, I guess just helping your patients and clients to feel better, more empowered to be able to get what they need out of those situations. And I think we're about at time, Shan. So we can certainly, unless anyone has any last minute comments that they'd like to share, we can kind of start wrapping up here.
I do.
Oh, Cheryl does. I just saw that, Cheryl.
Someone was going to say something. Yeah.
Okay. First, I'd like to, because I just completed the CHW program in December here in San Antonio with Dr. Martinez. And so I'm currently seeking employment. So other than that, I don't have that CHW experience yet as far as employment. So is it good to practice, like, when I do get that opportunity to practice at home with family and friends? Because I know that everybody learns in different ways, right? And everybody doesn't comprehend some of the jargon that is given to us, so I like to know, like, from your point of view, when you're first starting out, is it good to practice with family and friends?
Absolutely. That's one of the things I always say, and I don't think I said it today, but the Teach Back tool actually originated from the field of education back in I can't remember exactly when, but a long time ago. It's a tool that you can use in any communication scenario. So maybe you need to have better communication with your spouse or your partner or your mother or your daughter. Like, it's when you start using Teach Back and practicing it in your everyday life, it becomes like a habit. And so you find yourself doing it without even realizing it, but it really does help clear up some of these misunderstandings that people have. So yes, try it, try to use it with your employer, with your friends, with your family, and pretty soon it'll just be the way that you always communicate.
Also, if I could, I would like to share something, because you are talking about providers, and I don't know if you remember back in 2007 when we were facing the meningitis and a lot of people were dying at that time. Well, my brother, who's in a wheelchair, we didn't know at the time he was real sick, right? And we didn't. I took him to a hospital, and they just sent him home because you don't know unless you do a spinal tap that you have meningitis. So they just sent him home. And 2 days later, I started noticing he started having hallucinations. So I took him to another hospital. I got there about 7:30 in the morning and was there all day long. And they wanted to send him home from the hospital. I'm sorry about that. And I had to advocate for him, because if I had let him, because I have to remember, like, they're in a hospital, they don't know him, so they assume because he's in a wheelchair, maybe that's something that is normal for him, right? But as a family member, we know the norms of family, right? Or ourselves, right? And so we have to advocate on that part, because if I had allowed them to send him home, he wouldn't be here today. He ended up having meningitis, encephalitis, and MRSA, and they had to put him in a induced coma because they couldn't control the seizures. But I had to fight for him, like, as a sibling. I had to tell them, you are not going about to send him home, and if you do and something happens, this is not the last time you're going to hear from me. I said I would call Channel 5, I would call Channel whatever channels I have to call. I said, my Spanish isn't that well, but I will call 41 and 60, whoever will listen to me, because I'm not walking out that door and you're not going to send us home. And they said, well, the only way we can do anything is if we do a spinal tap, and that can be very bad. I said, I'm sorry, but my brother's in a wheelchair. I said, if this is going to save his life, then do whatever you have to do. Luckily, I advocated for him, because sometimes, you know, doctors, we expect for them to know everything, but they're human too, right? And so as a family member, it's our job, right?
Absolutely, Cheryl. And, you know, providers, like you said, they're human, they make mistakes, and they also have their own biases. I think I won't go into my story because we're out of time, but I think I had an experience that resulted in much delayed care for me because of assumptions that were made. And so, again, as CHWs and as your, you know, in your own families, being that advocate and using your skills and advocacy to help people is so critical. We can't state it enough. Thank you all for your time today. It is 1:30. We're going to go ahead and adjourn. Thank you for your wonderful sharing, Cheryl, and others today, sharing your stories with us. And we really appreciate it. So sorry for all of the technical issues. I don't know what happened, but thank you for sticking with us. Shan?
Sure. No, thank you. Just a point on practice. Please do use the scenario that we sent out. So there's a scenario that you can practice with a family member or friend. I put the link to get the CEU certificate in the chat. So please fill that out to get your hour and a half today. And we will meet in a month to talk about advocacy or policy. Melanie, you're up next again. No, you're not.
Next is policy, so that'll be Dr. Kenty.
Policy. Okay, and then we end with advocacy. So we will see you next month. Thanks for being here today and sharing this space. Goodbye, everyone.